Hello, and welcome to the Surgical Oncology Clinics podcast. I'm John Vasallo, the Managing Editor for Surgical Oncology Clinics here at Elsevier. Surgical Oncology Clinics is a quarterly publication consisting of review articles centered on a central topic important to surgical oncologists. In this inaugural podcast, we will be discussing the April 2021 issue on pediatric surgery, and leading the discussion will be our consulting editor, Dr. Tim Pollack, Professor and Chair of the Department of Surgery at The Ohio State University Wexner Medical Center in Columbus, Ohio. Joining him will be the guest editor of the Pediatric Surgery issue, Dr. Roshni Dasgupta, Professor of Surgery at Cincinnati Children's Hospital Medical Center in Cincinnati, Ohio. Welcome to both of you, and over to you, Dr. Pollack.
Thank you, John. As mentioned, I am the consulting editor of Surgical Oncology Clinics of North America. And I have the real pleasure today to have as our guest Dr. Dasgupta, who is the guest editor on this specific issue of Surgical Oncology Clinics. This issue of Surgical Oncology Clinics focuses on the management of pediatric cancer. You know, despite many advances over the last several decades, pediatric cancer remains one of the top causes of death in children. And amazingly, the specific focus on pediatric oncology has really only been established over the last 50 years. Surgical oncology in particular is very important and has become a clear subspecialty within the field of pediatric surgery. And there's been many evolutions and changes in the management of children with cancer over time. And therefore, there could be no more appropriate time than to have a specialized issue focusing on pediatric cancer in Surgical Oncology Clinics of North America. And as I noted, our guest editor is Dr. Roshni Dasgupta, and we are incredibly privileged and lucky to have her as a guest editor, as she is an extremely well-recognized expert in the field of pediatric surgery and pediatric oncology in particular. So Dr. Dasgupta, we'd like to welcome you today to the podcast, and we'd like to sincerely thank you on a wonderful issue of Surgical Oncology Clinics of North America. Welcome.
Thank you, Dr. Pollack. I think this is a wonderful opportunity for pediatric surgical oncology to have some recognition in the surgical oncology world. It is an emerging specialty, and as pediatric surgeons, we have become more specialized. People are doing fetal surgery and colorectal surgery, and pediatric surgical oncology has really become an entity unto itself. And the changes in the molecular and genetic profiling of tumors has really caused a paradigm change in surgical oncology in general, and particularly in pediatrics, where there are a lot of biological considerations in terms of treatment of these tumors and the prognostication of the tumor and treatment pathways. And it's very important as surgeons that we understand that. And this complexity has really led to this specialization. It used to be that pediatric general surgeons were sort of jacks of all trades, but that's really starting to change.
That's great. Well, thank you. Again, this issue, when looking through it, it's just an incredibly impressive issue. There's many important topics that were covered in this issue, including the treatment and surgical management of patients with a wide range of different tumors, including neuroendocrine tumors, various abdominal tumors, GIST, liver, renal. And really, the group of experts that you put together to write these articles is quite impressive. I thought with our time today, maybe we could touch on a few of the articles in the issue and perhaps highlight some of the more common tumors that we find in the pediatric population. And so to that point, I thought maybe we'd start off, if you will, talking a little bit about the article by Dr. Lopen and Dr. Ehrlich that was on nephroblastoma, Wilms tumor. Now, obviously, renal tumors are fairly common abdominal tumors in the pediatric population, being the second most common abdominal tumor behind only neuroblastoma. And I was wondering if you could comment a little bit about the diagnostic workup of these patients, and perhaps some of the changes in the therapeutic approach to these patients over the last 10 or 20 years, as highlighted in this article in the issue.
Sure, absolutely. Dr. Ehrlich and Dr. Lopen have done a wonderful sort of treatise on Wilms tumor. It is true, it is one of our most common tumors, and generally they present in children under the age of 4, usually with an asymptomatic palpable mass. So often this is found in a well check by a pediatrician, often on an annual exam. This subsequently leads to an emergency room visit and generally some imaging. Our imaging paradigm usually starts with an ultrasound. Subsequently, a CT or an MRI is done. Depending on what the tumors look like and whether there are genetic predispositions, generally the thought up front is for primary resection. Now, there are patients who may present with widely metastatic disease or disease that is quite extensive, particularly with tumors metastases to the hepatic veins and above the towards the in the retrohepatic cava. Those are some reasons where patients may not have upfront resection. But metastatic disease, unlike in other patients, is not a reason if the local stage it appears to be resectable that to undergo a primary surgical resection. So the field in Wilms tumor has really progressed. And that's, again, like I had mentioned earlier, the biological factors and the genetic factors have been really helpful in characterizing what our risk regimen should be. So the loss of heterozygosity at 1p and 16q are poor prognostic factors, as well as the gain of 1q. And about 5% of patients have that loss of heterozygosity at 1p and 16q. And those patients are known to require more intensive therapy. The patients that have 1q gain comprise about 30% of our patients, again, requiring more intensive therapy. When we consider the surgical evaluation of these patients, the things that have changed are that we've been able to realize that patients that are under the age of 2 that have tumors that are under 550 grams can actually be treated with surgery alone. So generally, the Wilms tumor has been generally thought of as requiring multimodal therapy, chemotherapy always, and surgery and sometimes radiation, depending on lymph node metastases and the presence of spill. But these patients that have these favorable prognostic factors can actually be treated up front without chemotherapy and actually not have some of the late effects. Again.
So maybe I could just follow up with a couple of questions, Dr. Dasgupta. You mentioned that many of these patients may present with metastatic disease, and even a subset may present with advanced disease with, even intracaval thrombus, et cetera. Can you talk to us a little bit about the role of preoperative chemotherapy for these patients? And I know in adult populations, we frequently will treat with preoperative therapy to assess for a response. And I'm wondering if this is the paradigm in pediatric patients with advanced disease. What type of chemotherapy do you use, and what type of response rates do you see in these patients?
For patients who have disease that looks unresectable up front, these are patients that are treated with neoadjuvant chemotherapy. Generally, there are two different paradigms that have been used in North America and Europe. In North America, we tend to operate on patients up front, whereas in Europe, in the SI protocols, we tend to give those patients chemotherapy and shrink the tumors. And so there is a paradigm difference. The ones that we in North America tend to give chemotherapy on are those ones that potentially have that very high risk of rupture or have extensive cable metastases.
And then you touched on kind of the genetic profiling of these tumors. And I was wondering if the genetic profile of the tumor has a role in dictating therapy. Vis-a-vis giving neoadjuvant chemotherapy up front, proceeding directly to surgery. Do you use any of that genetic data to direct therapy at this time? Or is the genetic data largely more prognostic purposes rather than of therapeutic purposes?
So the genetic data has led us to increase therapy for patients with loss of heterozygosity at 1p and 16q. But beyond that, it doesn't really dictate our surgical management. The surgical management is primarily based on anatomical factors.
And then finally, maybe you could just touch a little bit on the overall prognosis of these patients and follow-up surveillance, recurrence rate.
Yeah, these patients do well. Generally, if you take all comers with patients with Wilms tumor, they have an over 90% survival. So the push in Wilms tumor therapy has really been reduction of therapy. How do we prevent late effects? How do we prevent the long-term issues that come with significant chemotherapeutic regimens and radiation regimens. So we're really hoping to decrease the amount of therapy that's required and really allow these children to grow up without significant late effects.
That's great. Well, thank you. I think let us pivot maybe to talking a little bit more about liver tumors. As an adult liver surgeon, this is a topic that is near and dear to my heart, the topic of liver disease. That being said, however, liver tumors in pediatric patients can be quite different than they are in adults, with malignant tumors being more common perhaps than a number of benign lesions that I may frequently see in my clinic. And in particular, I was wondering if you could just share with us a little bit about the variety of liver tumors that pediatric surgeons see, whether they be epithelial or mesenchymal in origin, and how one proceeds with a workup and a diagnosis of the child who presents with a liver mass.
About 2/3 of liver tumors are malignant in children. There are definitely in infancy a lot of benign tumors that we see, particularly those are infantile hemangiomas. And these are different than what adults call hemangiomas in the liver, because those are really venous malformations. Infantile hemangiomas do grow and proliferate and then go away. So unlike what we think about when you mention hemangiomas in adults. So hepatoblastoma is the most common liver tumor in children. And generally, again, they have a particular age group, usually under the age of 3 is when they present. And then also see sort of a mixed type liver tumor where there is some hepatocellular components in that histology, as well as some of the fibrolamellar hepatocellular carcinomas that we see in later teenage years. They do all present in a different way. So when we think about the young children, again, it's just usually a liver mass. Generally, it's not any functional deficits. These are not children that generally have any underlying liver disease. So unlike in adults, where you think about cirrhotics and patients with underlying chronic liver conditions, these are patients that usually have these de novo. This is also true with patients who develop pediatric hepatocellular carcinoma, who generally don't have an underlying liver diagnosis. It is true that the patients who do have some of the metabolic storage diseases and things like that are congenitally acquired do require surveillance for the development of hepatocellular carcinoma. However, the vast majority don't have underlying disease.
And then if you could maybe touch specifically on hepatoblastoma, which is a tumor that we don't see in the adult population. And unlike standard general hepatocellular carcinoma, which we think is chemo resistant generally, hepatoblastoma is usually chemosensitive. So could you shed some light on the treatment paradigm for that cancer that is chemo sensitive, the role of chemotherapy with regards to surgery, preoperative, postoperative, adjuvant chemotherapy, things like that?
Sure, absolutely. So with hepatoblastoma, we do think of most of these patients as being chemosensitive. AFP is usually elevated, and there's some very clear sort of diagnostic imaging that's quite characteristic of hepatoblastoma. Most patients are now staged with something called the pretext staging system. The pretext staging system is done prior to any sort of treatment, and patients are divided into pretext stages based, and then also some annotation factors based on vascular involvement, which hepatic veins might be involved, the presence of metastatic disease, multifocality of the tumor. Patients that are pretext 1 and 2 are generally treated up front with surgical resection. Those are generally patients with a nice margin around the hepatic veins and are easily resectable. Patients that are pretext 3 and 4, which have multifocal disease, are generally treated with chemotherapy up front, and then usually between 2 and 3 cycles are then treated with surgical resection. There are patients who may have multifocal disease and after 2 cycles of therapy have minimal response, and those are patients we tend to refer to transplant centers, as transplant is a viable option for hepatoblastoma in these cases.
That's great. One other thing that drew my attention when I read this really wonderful article by Dr. Myers, Hiyama, Saderna, and Tiao was their mention of the Pediatric Hepatic International Tumor Trial, this collaborative multi-center trial that prospectively investigates pediatric liver tumors. And I really think that pediatric surgery community has done such a wonderful job with these multi-center collaborative prospective efforts. So I was wondering if you could touch on that in general, and then specifically talk about how this particular collaborative effort has led to greater insights in how we can treat children with pediatric liver tumors.
I think that we have to remember that pediatric tumors are rare. When we think of them in the context of our most common tumors, they're between 700 and 800 cases a year. So if you think about how many liver tumors or how many breast cancers and lung cancers in the adult world, you know, there are orders of magnitude less. And so in order to be able to study these, understand outcomes, we need to share data internationally. And then you'll see that many of the authors in this volume are from outside of North America. And it is integral to have these cooperative groups that can share data and come up with common treatment paradigms. And it's happening not just in liver tumors, but in sarcoma, in neuroblastoma, in germ cell tumors, that we're sharing data, we're coming up with consensus on how we treat patients, both from a chemotherapeutic perspective, from a radiation perspective, and from a surgical perspective. And, you know, by coordinating our efforts, we can then really have the power to answer some really important questions, because without being able to amalgamate our data, when everybody has, you know, 100 or 200 cases with a lot of variability, we're never going to be able to say anything important and have the power to make conclusions and change treatment. So the FIT trial has been a great improvement in terms of how we share data. It's not only in Europe, but it's also including our Japanese colleagues. And so it's a really sort of international collaboration that meets now with COVID, not as often, but has really continued to look at data centrally, does radiological reviews, and has really improved the care of these patients, and thinking about new study type research questions as well based on the data that they're getting.
That's great. Well, that was a really informative, insightful discussion around pediatric renal and liver tumors. I'd like to change our focus a little bit now and maybe focus a little bit more on technique. Another article that drew my attention in this issue is the article by Dr. Wynan and Davidoff on minimally invasive techniques in a pediatric surgical oncology population. And I was wondering if you could discuss with us a little bit about minimally invasive approaches, laparoscopic approaches, the use of the robot in the pediatric surgery population, what specific indications, perhaps for minimally invasive surgery, have you seen where this approach has been most widely adopted?
So minimally invasive surgery is very attractive for multiple reasons. You know, patients do better. There's less long-term issues and potentially less issues with adhesions in the abdomen, problems within the chest. Minimally invasive surgery has tended to be primarily diagnostic as to this point in terms of lung nodules and doing thoracoscopic biopsies. It is used in often with ovarian tumors quite frequently, and there is going to be a new study looking at thoracoscopy versus thoracotomy in patients with osteosarcoma. The role for the robot and some of our other things are a little bit limited because of the patient's body size. When you're looking at trying to get into a tumor in a patient who weighs 4 or 5 kilos, the robot's often very difficult to use, particularly with the size and the ports that are available now. It has been used for things like retroperitoneal nodal dissections in patients with rhabdomyosarcoma in the paratesticular region, and that's definitely been used, but it has limited uses based on patients' body cavity. Partial nephrectomies are performed in patients with renal cell carcinoma, but this is not generally practiced.
And then one perhaps controversial topic around minimally invasive surgery is just the learning curve, and also how do we train pediatric surgery fellows? And we're already talking about a subspecialty where you're dealing with rare diseases. And even in adults where we do pancreatic surgery, which is relatively rare, finding enough cases where minimally invasive surgery is applicable so that one can get the critical number of cases to overcome the learning curve can be a challenge. So I imagine in pediatric surgery where you're not seeing a ton of patients perhaps with a Wilms tumor or a liver tumor or whatever tumor it may be. How does one address this learning curve issue when it comes to minimally invasive approaches?
And that's a really good question. I think we use minimally invasive approaches for other aspects of pediatric surgery. And remember, we train pediatric surgeons who do thoracoscopic tracheoesophageal fistula repairs and things like that. So they are used to small spaces. The particular surgery, we hope that those skills are translatable, but it's really important to remember that you need to do the right oncological operation, regardless of whether it's minimally invasive or open. You need to have the same effects in order to get the best response. So I think that's sort of the paradigm that we must remember when we teach our fellows, that if they don't feel that they can do the same operation as they can do open, we shouldn't be doing this minimally invasively.
Moving on, another article that really grabbed my attention was one that took into account some of the other considerations that may be somewhat unique to our younger patients or pediatric or adolescent patients who have cancer. And that was the article by Lautz, Burns, Rowell, on fertility considerations in pediatric and adolescent patients undergoing cancer therapy. So I was wondering if you could talk to us in particular about some of the issues around fertility preservation as it relates to surgery, chemotherapy, as well as radiation therapy, and perhaps in particular, which diseases perhaps this comes up the most in when you're treating, and what are some of the conversations that are had with young women who are undergoing cancer therapy around future fertility considerations, egg preservation, egg harvest, and things like that.
This is a really opportune time to talk about fertility because it's become a significant issue, particularly in young adults and survivors of pediatric cancer. Now, in pediatric cancer right now, we have about an 85% overall cancer survival. So there's a lot of survivors of cancer out there. And one of their biggest concerns is their ongoing fertility. Fertility consults and that fertility, the attention to fertility really hasn't been all that present since probably in the last 5 to 10 years. It's been an important thing. Basically, when we think about fertility, we want to offer fertility consults to all patients undergoing any sort of chemotherapy. There is a risk assessment that's done that's really based on what type of therapy that they're getting. So specifically, their cyclophosphamide dose, if it's greater than 4 grams per meter squared, is a significant risk of premature ovarian insufficiency and as well as azoospermia. When we think about radiation, the exposure of testicles to more than just 4 gray of radiation can actually cause permanent azoospermia. And 4 gray can happen just with scatter from radiation, so it's a very small amount of radiation. In females and young girls and adolescents, usually between 10 to 15 gray of radiation, which again can just be achieved with scatter, can cause significant ovarian damage. And in the pediatric population, we need to think about the prepubertal patient and the postpubertal patient. The prepubertal patient, is important because they have not yet reached puberty, and therefore there's limited mechanisms in how we can maintain their fertility. In boys, it requires testicular biopsy and tissue that can be preserved. As of yet, we have not figured out how to mature that testicular tissue. And then for girls, again, that prepubertal ovarian preservation is also important, but again, that maturation is not yet been realized. In the postpubertal patient, it's much more like an adult, where we think about ovarian stimulation. Usually this requires about 2 weeks of hormonal stimulation. And in boys, we generally tend to do sperm banking. So it's a little bit easier in the postpubertal patients, but it's really important to discuss this with all patients undergoing any sort of chemotherapy or radiation regimen, as it becomes one of the most important concerns of survivors.
Perhaps a little bit of an adjacent topic, but I was wondering if you could comment on radiation exposure from imaging. Since you mentioned a couple of times during your comments that even low-dose radiation can potentially cause fertility problems. And I know in the adult population, we rather ubiquitously use CAT scans. So how do you follow and surveil patients with pediatric cancer? How do you work them up? How concerned are you about radiation exposure? How does that factor into your decision making? And how do you mitigate that risk? And how do you discuss that risk with your patients?
Yeah, so if you look at some of the general studies in pediatric radiology, we do tend to use ultrasound and MRI much more commonly than we do CT scans. And that's even with the diagnosis of appendicitis. We tend to be pretty judicious in our use of radiation because of the known long-term risks of developing malignancies. Now, in these patients who already have malignancies, we also definitely want to be judicious in our use. And they tend to be followed either with plain radiographs or MRIs, really depending on the disease process. But sometimes ultrasound is also quite amenable to use for follow-up paradigm regimens.
Great. Well, I really owe Dr. Dasgupta a great debt of gratitude for her work to identify such a wonderful group of pediatric oncology leaders to contribute to this issue of surgical oncology clinics of North America. This team of authors has done a very skillful job in highlighting the important and relevant aspects of caring for children with cancer. And I'm convinced that this issue of surgical oncology clinics will serve faculty and trainees well in understanding the latest state-of-the-art practices related to the care of pediatric cancer. So again, Dr. Dasgupta and all of the contributing authors to this issue of surgical oncology clinics of North America, thank you very, very much. So with that, again, I'm Tim Pollack, consulting editor for Surgical Oncology Clinics. I thank you for joining us today, and I'll turn things back over to John.
Thank you for joining us for this inaugural podcast for Surgical Oncology Clinics. The series is available for individual print subscription with online access or individual online-only access. Visit www.surgeonc.theclinics.com to subscribe. The series is also on the Elsevier electronic platforms Clinical Key and Science Direct. Be sure to follow us on Twitter @Surgical Clinics and subscribe to the podcast on iTunes or the Google Play Store. Thanks for listening.